Hello and welcome to the Health Junction. I'm your host, Ruth Magak. This is where we have healing conversations that keep you inspired, informed, and aware. We are hosting our very first episode to speak about breast cancer in October during the Breast Cancer Awareness Month. We are having Dr. Wanda, who is a clinical radiation oncologist here at the Nakuru County Regional Cancer Center, on ground to inform you what really breast cancer is, from diagnosis, treatment, and beyond. So welcome our viewers, our listeners, from wherever you are. We hope you're going to enjoy this conversation. Thank you for joining us, Dr. Wanda.
My name is Dr. Wanda. I am a clinical and radiation oncologist by profession. That means I'm a doctor that's able to treat cancer using both chemotherapy and radiotherapy. I am very happy to be here today, and I feel I'm very passionate about my work, not just necessarily just the treatment of the patients, but also the well-being of the patients. I feel as doctors we really focus on the science behind it. We focus about the medications needed, but sometimes we forget the person behind it, and maybe some of the reasons that has made that person come late for treatment. So I feel this is an important conversation, and I'm hoping many will listen, and so that it impacts their lives. And if they share this information even with one more person, then they'll have made a very big difference in the lives of someone. And such conversations are life-saving. So as much as doctors we are busy, I try to find some time to have these discussions, because I know what has been known about Kenyans, they spend a lot of time on social media. So if you want to meet them with information, then this is one of the best avenues to give information in a way that's palatable, in a way that they'll be able to assimilate. I'm very happy to be here. Thank you for our listeners who've joined us. I think this is a very important topic. And I think as we discuss about the Health Junction, it's where we all meet. It's where everything interacts, and it's a junction. So as healthcare workers, as the public, as friends, as family, this is really an important topic, and I am grateful that we had this opportunity to have a discussion.
October is pink, pink ribbons, walkathons, everybody is speaking pink, and thanks for wearing pink.
Thank you.
With a very nice pink ribbon.
Yes.
Looks so good.
Yeah.
So tell us about breast cancer, because everybody out there, the public, still think it's something, some disease, breast cancer is out there. How close is it to us as a community, in the nation, in the county, and in the spaces we live in?
So that's very true. Most people, when they hear about cancer, especially breast cancer, it's normally a concept of other people, you know, they don't relate with themselves. So yes, breast cancer is really with us. When we look at the statistics even globally, then you find breast cancer is leading in terms of incidence. So it's the bulk of all the cancers we see. In our Kenyan setup, it's the same. We have breast cancers being number one in terms of incidence, but in terms of mortality, cancer of the cervix is higher. So what we are saying is that many women have breast cancer. And I think most people imagine that breast cancer will be painful. And most people wait with a mass. Like this week I've seen someone who has had a mass for more than 6 months. I saw someone else who had a mass for 8 months. Someone has had it for a year, but has not taken any step because it's not painful. So I think what people mostly imagine cancer to be is a painful disease. However, in the early stages, there's no pain. Absolutely no pain. So this is why screening is important, because we are able to catch cancer early. We are able to catch it before it becomes a malignancy. We are able to catch it before it's gone even to the nodes, before it's gone to other organs. So it's really important for us to understand why screening is critical. Because if we catch it very early, it is very easy to handle. You need fewer procedures, fewer treatment options, but you end up doing very well. However, when you stay with a problem for so long, the problem now becomes advanced, either locally or it has spread to different organs. And when it's spread to different organs, it's a challenge, because what happens is now the treatment options have to be more diverse, more extended for a longer period of time, and perhaps what would have been just a surgery for you might now need you to have chemotherapy, might need you to have radiotherapy, might need you to be on treatment for extended periods of time. So what are we saying? Breast cancer is here with us. Some statistics even says out of 10 women, at least maybe 7, 4 to 7 will get breast cancer. So on random, if you're in town and you pick women, it's very possible of the 10 you've selected, after a while, some of them will have breast cancer. However, you find most people, when we talk about screening, they're very scared. Most people say, what you don't know
Doesn't hurt you.
Doesn't hurt you. And they say, the
Yeah.
moment I know I have cancer, I will die.
Yeah.
And I think that's a very big myth we need to demystify,
Yeah.
because knowing you have cancer
Yeah.
or you have cells that are cancerous early is actually life-saving.
Yeah.
We have a huge population of survivors who are alive today because their cancer was diagnosed early. I have a privilege of having been in this in the facility where I work, in Nakuru PGH hospital, and we were here since 2018 when the center was opened. And we have so many survivors from that time to now who are doing well. Reason being, most of them were caught at early stages. For those maybe we found in very late stages, then it's been a challenge. There's still perhaps ongoing treatment. It hasn't been a very smooth ride. But those who were caught early, majority are alive. But I think our concept of what cancer is and what it stands for is most of the people who've heard of cancer, they only remember that very sick patient in hospital.
Yeah.
Or they went for a funeral and what was written there was cancer. So we associate cancer with death. However, I think even the media should also sort of change the narrative, because you find those very touching, heart-goring, eye-teary stories are those of very sick patients. Those are not doing very well. However, we have people who are teachers. They've had breast cancer, they've been treated, they're fine. We have students who are in school, they've had breast cancer, they're treated, they're fine. We have lawyers, engineers, and they're back to work. That's just to say, I think how we conceptualize and portray cancer also needs to take a 360 turn, so that we are looking at it in good perspective. That yes, it is a disease that's serious, but yes, many are doing well. And I think when we do that, then we'll encourage those who have been diagnosed to gain the courage to face the disease, to face the treatment, to face family, and also reduce the stigma that is associated with cancer in general.
What are kind of the some symptoms they would look out for that would inform them to go and get checked?
All right. So first of all, the culture we want to instill is a culture of screening. That means you have no symptoms
At all.
It's just the age.
Yes.
So as soon as you hit 40, we expect all women, and I repeat, all women, to go for a mammogram. A mammogram is an X-ray of the breast. So the breast is put and two paddles, press on it, and an X-ray is taken. Some of the cancer, when they begin, they have calcifications. You're able to see even before it's a mass. So even the slightest change within the breast can be seen using a mammogram. So when we talk about screening, we're telling all women, are you 45? Are you 40? You've reached 40. Let's do a mammo. For those who have family history of breast cancer, then we want to start even earlier than that, because we know there's a 10 to 15% chance that breast cancer, and many of these cancers we talk about, can be hereditary. So if you've had a relative who's had breast cancer, the breast cancer came early, maybe in the age of 30, to your relative, it's more than one person with cancer. Sometimes it's different cancers. Or we've tested you and we've confirmed you have the BRCA gene, BRCA1 or BRCA2 gene, which tells us you're at risk of getting cancers associated with that gene. Then we start your screening differently. However, majority of the patients we find cancer begins from the age of 40. That is a global figure.
Yeah.
In Kenya, we catch our cancers very, very early. So we have 20 years old who've been diagnosed with breast cancer. We're 30 years old. So our age paradigm in Kenya is different. Our cancers come earlier than what happens in the West. So that tells us it's important to be vigilant. For those who are below that age, going for a clinical breast exam is really encouraged, where you go, a health professional who on the regular is examining breast, because it's also a skill. Examining a breast is a skill. Unfortunately, we've had some people go to hospital and then they're told, don't worry, that's just an infection, whereas it was cancer. So going to a healthcare professional who has a lot of experience in examining breast is quite important, because they'll be able to pick up even very subtle changes that could have happened within the breast. So screening, there's a clinical breast exam. Number two, we have now the mammogram. We can also do an ultrasound. For those who are below the age of 40, we can do an ultrasound. We also use an MRI. An MRI helps us, especially for women who have dense breasts. Why we say the age of 40 is because the density of the breast changes over the age. And when you get to 40, then the density of the breast becomes lighter. So that means they become more flaccid. Some people maybe joke about it, they call it fallen soldiers. So just the density of the breast becomes less. So it's easy for the mammogram to pick up changes. But there are women after the age of 40, they still have very dense and straight breasts. So for those, a mammogram might not be the best imaging modality. What might be preferred might be the MRI, because it can be able to pick out lesions in the breast.
There's so much fear around mammogram. Some women say it's painful. Some people just have unknown fears. People who've never known even how the procedure is done. What would you tell them to demystify those fears?
Well, I think it's the fear of the unknown.
Yeah.
I think if you've never done something, you've never gone somewhere, a journey to a place like Garissa, if you've never been, seems like forever, an eternity.
Yeah.
But when you come back, then it becomes bearable.
Yeah.
So I feel perhaps it's more of discomfort than pain. There's certain characteristics a person might have. If you're breastfeeding, we might not do a mammogram at that time. If you have an open wound, we might not do a mammogram at that time, just because of the compression. We don't want to give you more pain.
Yeah.
But for a woman whose breast not lactating, they're not too dense, then it's not a painful procedure. Some women have mentioned it is uncomfortable, but not necessarily painful in nature. There's that discomfort because, yes, there's the pressure because they have to spread out the breast tissue so that the x-ray can work well. But really, it's not painful. So what I would say, I guess, being it's the first time, what I encourage most friends is to make it a habit to do things together. So we make arrangements to travel together. We make arrangements to meet up for coffee. We can make arrangements and say October. Yeah, to get screened. And that would make it sort of like an activity we do together so that we can support those who are very scared. We can support those who are very worried. And then it stops being a big deal. And then we'll remind each other every October, guys, when are we going for screening? Then it stops being this very scary affair to be something that is doable. Something you can actually walk into and get done. And sometimes when you do it as a group, then you already psychologically support one another. Psychologically, you know, I'm not alone. Psychologically, you know, we're doing this. And it's just healthy lifestyle. So I think as friends, as groups of women, it's very important to do that. But having said that, I think I have a problem with pink because pink is considered a feminine color.
Yes.
However, men get breast cancer too. And I think sometimes when we make it so pink, it looks like a reserve for the female. So these instructions we're talking about to look at your breasts, it applies to men too. Men are always very shocked that they have breasts, but newsflash, men have breasts. They are not as big as those for women, but they have breasts, and they can get breast cancer too. So the important thing is to look out for changes in the breast. I think men and mirrors also don't have a very good relationship. But it's good for a man to have a mirror that can even help them look at their chest. Because sometimes the changes initially are very subtle. It might be just a swelling, one breast is larger than the other. A skin change, the skin looking like a tangerine. If you know a tangerine, it's sort of rough on the surface and has dots. So sometimes the breast can have that perception. We have what is called puckering, where you find a section of the breast is pulled in. So it looks like a dimple. You never had it before on your breast, but now there's a new dimple. Or the nipple, all along the nipples are facing out, then you notice one is retracted. You know, it's pulled in. So sometimes it's the tumor that is pulling the nipple back in, and it needs to be looked at. Sometimes it's just a discharge. You press the nipple and you notice a bloody discharge that's coming out of the breast. But remember, painless. For some women, what they notice first is a swelling in the axilla. They don't have a mass on the breast, they just notice the axilla is swollen. And sometimes it's non-painful. So they're like, I'm fine, I can go to school, I can cook, I can take care of my family. But it's important for us to be aware about our health. Others present with an ulcer, that's like a lesion on the breast, and that is indicative of a problem within the breast.
That's so thoughtful and innovative. Group screening. Perhaps I will tell my friends, let's go.
Me and my friends will do it in October, so we are supposed to do it in a week's time. Where we'll just go for the investigation, get an ultrasound down, and we keep reminding each other. So when one forgets, the other one is there to put them on check.
So women, please go and get screened. So for the men, how do you do? Because now I'm imagining their breast the way it is. How do you do the mammogram, or they now automatically go for the MRI?
So depending on the size, you know, also different men have different sizes of breasts. When you're very hefty, then you have larger breasts, just because of the estrogen component in the fatty tissues compared to a lean man. So for those who have pendulous breasts, then we can be able to do a mammo. However, for theirs, because there's no much tissue, it's very easy to pick it out, because any increase in size will be notable, especially if someone has a totally flat chest. So what we recommend is when they look at themselves and notice a swelling, then they come for a clinical breast exam. Then we can do an ultrasound for them, because if there's nothing to compress, then an ultrasound might be better,
Yeah.
or an MRI to look at how the breast look like, in order to help and see, can surgery be done, or should we start with chemo, and those kinds of discussions. Yeah.
How has the technology of both screening and treatment evolved over time in terms of breast cancer?
I think the most beautiful thing is it was decentralized. There was a time all the screening had to happen in Nairobi.
Yes.
Then the other place it had maybe was MTRH. And you see, that was very difficult for someone who does not have financial means. Traveling all the way to Nairobi just for screening was really an uphill task, was almost impossible to achieve. So I think decentralization, ensuring mammograms are available in every county, has made it accessible to the population. The fact that the previous insurance scheme that we had did not cater for screening, but currently the SHA is able to pay for screening. So that means most people are saying the cost is too high for screening, it's exorbitant, we're not able to afford, we can't do the scans. But at this point, the screening is covered. So really, I think they're really trying to reduce all of the bottlenecks that were there, that were making people not go for screening, so that it is more accessible. And I feel the fact that we even have MRIs in the counties is also really helping, because access to care. The other thing that I feel that has really evolved is the availability of treatment facilities. Many years we didn't have radiotherapy, chemotherapy in the counties. It was just Kenyatta. And the waiting times were long. For radiotherapy, it was about 6 months to a year, because everybody had to go there. But now we have Garissa, Mombasa, Nakuru, we have MTRH, Kenyatta, KU. You see, those are very many radiotherapy centers, and there are even more chemotherapy centers distributed in the country. So I think that evolution has helped. Also, previously, we didn't have what is called targeted therapies. We didn't have immunotherapy, which is very important in breast cancer, especially at the metastatic level, where we want to give treatment that has less toxicity, but high efficacy. So those modalities of treatment were very, very expensive, but there have been access programs through KEMSA that have allowed the cost to come down. There have been private-public partnerships that have allowed cost to come down. Like the drug like Herceptin, one of the drugs used for breast cancer quite a bit, was about 200,000. You need 18 of those.
For the whole treatment?
For the whole treatment. So you can imagine 250, 18 times. It was really almost impossible. But now, because of the private-public partnership in the government institutions, a patient can get it for 35,000. And you see, even when it's 35,000, the SHA is able to cater for it. So it's really helping patients to be able to access care, which was not there previously. So I think there have been great strides. Things like the PET scan that would make us send patients all the way to India. There are so many now in the country. We have more than 6 in the country. Yes, they are all centered within Nairobi, but some you don't need to put a top up. You find just your SHA is enough to pay for you. And that has really revolutionized care to ensure we can give comprehensive breast cancer care within the country. So the reasons really to motivate one to leave the country for breast cancer treatment are almost not there. The government has also really invested in training. So we have oncologists trained within the country. Previously, people had to travel abroad, either to South Africa or the West to be able to be trained. But now University of Nairobi has a training for radiation oncologists, has a training for medical oncologists. There are many colleges that are offering radiotherapy treatment for the therapists. We have medical physicists being trained, nursing for oncology. They have very many. So that means even the workforce that we have been trained within our country borders. They understand our situation. They understand the population. So really, training for us is quite beneficial.
You practice at the Nakuru County Referral and Teaching Hospital, which is the regional cancer center for South and North Rift. Serves quite a number of counties that are surrounding and even beyond. So what would you tell someone who doesn't know that we offer these services here, and tell us a bit about that space?
Right, so the Nakuru Regional Cancer Center has blossomed into a facility that's really beautiful. When we began in 2018, we were able to offer chemotherapy and definitely the surgical aspect, because we have very many surgeons in the hospital, so surgeries were done and chemotherapy could be offered. However, the great aspect about radiotherapy was not available. So you would find, you see a patient, you give them chemo, they get surgery for breast cancer, then they need radiation. You send them to Nairobi, and the moment you tell them you need to go to Nairobi, tears flow.
Yeah.
Because they're wondering, they've never been to Nairobi. They need to be there for 3 weeks. They don't know anyone who lives there.
Yeah.
It was quite devastating. And we saw
Yeah.
many recur. The cancer comes back because they were not treated effectively.
Yeah.
So it was quite devastating. However, we're very happy to know that now we have radiotherapy services here. So it's comprehensive. We have the surgeons, we have the gynecologists that can offer gynecological surgeries, we have chemotherapy, we have targetable agents, and we have radiotherapy. So really, it's a comprehensive approach to cancer care. And for breast cancer, really you need nearly all those modalities. You might need chemo, you might need surgery, and you might need radiotherapy. And having them within the bounds of the county is really important. And then being within the county, it means the access to the medications is at a cheaper rate compared to what you'd get outside. Access to radiotherapy is closer to home, which makes it easy for patients to access. And since the facility is SHA compliant, it has really helped many patients be able to access care.
Finally, talk to someone who perhaps has just recently been diagnosed with breast cancer. What would you tell that person? And not just that person, as the community who live around that person. How can we support them? Or how can we support people who know someone who has already just been diagnosed with breast cancer and they don't know what to do, they don't know where to start?
So I feel the first thing I would want to tell the patient is one, breast cancer and cancer in general is not a death sentence. I think people hear the word cancer and they just see the end. But it's not that way anymore. Advances in medical care, advances in targeted therapy, advances in immunotherapy are making cancer not a death sentence. So having cancer is not equal to dying. So what are we telling the people around them? Already just having a diagnosis of cancer is emotionally draining. These patients need a lot of love and support to know that they can fight this journey, they can walk through this journey, and they can come out as victorious. So for the patient, it's important to really follow instructions of your doctor. I think what is heart-wrenching for us is sometimes somebody gets a diagnosis of cancer in January. Then they say, no, I want a second and third and fourth and fifth opinion. And by the time they're settling down on treatment, it's October. 10 months is a long time in cancer care. It's very important when you get your diagnosis, let us start treatment. Let us not waste time. Let us start treatment immediately. Actually, one of the quotes I normally say is, get to know cancer today, start treatment yesterday. Just to put the importance of, it's really important to start treatment. So it's not a death sentence. We have qualified healthcare professionals in the country. We have very good standard medication in the country. We have radiotherapy of good quality in the country. So it is possible for you to be treated for cancer within the country. And even within the bounds of Nakuru, it's very possible for you to be treated for cancer.
You meet patients, cancer patients, breast cancer, cervical, different cancers every day in your work. What keeps you going? What keeps you hopeful? And what role can we also play as a community, as families of these people that are undergoing treatment? And what can we do to also empathize with them and also remain hopeful through the journey?
So every day, yes, I just see cancer patients. So what keeps me going is their smile. It's not a very easy journey, and I think it's one of the most challenging things a person will go through as an individual. So seeing such a patient afford a smile after visiting your clinic or after getting their treatment, they are doing well, and them telling you, I didn't think I would get here, is really a reward, because every time someone is starting treatment, you're always telling them, you will be fine. You can do this. Others have done it. You link them up with people who've done well. And they meet them. And then now in future, now they become the support system. So they tell them, no, when I came, I didn't think I would make it. But I talked to so-and-so. They gave me the strength to go on. That keeps me going. But also for oncology health practitioners, I actually have advice. It is an occupation where we give a lot. It's very important to take care of yourself. Otherwise, it's very easy to get burnout. It's very easy to get depressed because our patients sort of become our family. The treatment is prolonged. So we see you, we meet your relatives, we meet your family. So we are in the journey. I always tell my patients, sometimes when I send them for CT scans, even me, I'm saying, oh, please, I am hoping everything is okay. So we are in that journey. So it's important for oncology health practitioners to do what is called self-care.
Yes.
Remember to take care of yourself, do what you love, and it's important for you to go for debriefing sessions.
Yes.
There are going to be those cases that will remain indelible in your mind.
Yeah.
And it's important for you to learn how to cope with the emotions you felt during those challenging times,
Yeah.
so that you're able to move on without a problem.
Yeah.
So in my honest setting, I feel oncology staff need to take care of themselves.
Yeah.
For the patients, just follow instructions. If you do not understand, remember it is your right to understand the care you're being given.
Yeah.
Please ask questions. Our country, people don't ask questions. So the doctor does all the talking, but it
Yeah.
is your right to understand.
Yes.
What is the treatment? What are the side effects? What are other options?
Yeah.
Please ask questions. Most doctors are willing to give you answers. They might give you the information they feel there is enough, but if you have a question, please ask them. Go to hospital with a notebook, because when you leave the door, you will remember all the questions you wanted to ask, but you didn't.
Yeah.
So I always recommend have a notebook, write questions, your relatives' questions, your family's questions, so that the next visit when you come, you sort of have a guided discussion during the meeting. For the rest of the community, I feel screening is a big deal. Let us encourage each other to screen, because if we catch it early, we'll have more success stories.
Yes.
And when we shift the paradigm, it's just like in the HIV world.
Yeah.
When HIV began, even on the roadsides, you would see a very emaciated man with a metallic cup and spoon.
Yeah.
And that was to help us fear the disease. However, when we found the assumpters who are doing well, who are at work, able to talk about it, the paradigm shifted.
Yes.
So I think we also need to have a paradigm shift when it comes to cancer,
Yep.
so that we have more people coming out to discuss their stake. Where are they? What was their journey like? And now that they're reintegrated back into life, it works well. The other thing is giving cancer survivors an opportunity.
Yes.
An opportunity to speak, an opportunity to say their challenges, an opportunity to have decision making.
Yeah.
Positions, because they totally understand what it felt to go through the treatment.
Yeah.
They have actually worn the shoe. So listening to them is a big deal.
Yep.
And allowing them to reintegrate. I think sometimes the stigma goes beyond just the treatment. Such that you've applied for a job as a cancer survivor, and if people get wind you had cancer, they're like, let's not give her a job, she had cancer.
Yeah.
But cancer is not a life sentence.
Yes.
There are people who are treated and they remain cancer free.
Yeah.
So if I was a doctor and I got cancer, then that's my profession. I should be able to be reintegrated back to work. If I was a teacher, then I should be able to be reintegrated back to work. Yeah, so I think it's very important for us to give grace to those who are survivors, allow them into their workplace, so that we can have integration of the survivors back to work.
Thank you so much. It was nice to have you.
Thank you.
Anything else you'd want to take to?
So this is October, guys.
Yeah.
Don't let it pass. We are wearing pink, so please wear pink. Talk to one person. Encourage your friends group. Please, let's get screened. Breast cancer can be treated in Kenya. The cost is not exorbitant. It can be done. Screening is possible, even using your SHA. Please come to hospital. We are here. We are ready and happy to serve you.
Thank you so much. Yes. It was nice talking to you.
Thank you.
So to all our listeners, our viewers, those who have had this conversation, please go and get screened. Encourage someone to get screened. You have had early detection, early diagnosis. It will save your life. And immediately you're screened. If there is a problem, start your treatment early enough. And this is October. Talk to someone. Get screened. Man or woman, you can have breast cancer. This is the Health Junction, and I have been your host, Ruth Magak. Thank you.